Welcome to this lecture. I'm going to be discussing the hierarchy of occupational therapy knowledge. Hopefully it's going to be a short lecture. So in this lecture, I will be looking at the way in which occupational therapy knowledge is organized. So occupational therapy knowledge is pulled from a wide range of sources, wide range of disciplines. If I take you back to 1917, when those 6 people came together to come up with a profession called occupational therapy, none of them, or none among them, was actually an occupational therapist. It is people who had background in medicine, psychiatry, nursing, social work, architecture, engineering, administration. So it's inevitable that for us to come up with occupational therapy practice, we need to pull on the ideas and values that are coming from a wide range of disciplines, combine them, and then filter them to actually develop occupational therapy practice. And I like what the great theorist, occupational therapy theorist, Anthony Mosey put across, illustrating this in the form of a funnel. We were looking at the wider part of the funnel as the philosophy, OT philosophy, and then as the knowledge is being filtered through, we then generate occupational therapy theory or our conceptual models. And then from our conceptual models, we then drill down to what we call frames of reference. And then from the frames of reference, we then are able to decide on what assessments and interventions to use with our service users. So the first part, occupational therapy philosophy, and I'm using philosophy and paradigm interchangeably in this context. So occupational therapy philosophy defines the nature and the purpose of occupational therapy. And we know that occupational therapy philosophy is centered around occupation, with aspects including looking at health as the outcome of what people do. And we know that what people do in occupational therapy, we call those occupations. Also including aspects of taking a holistic view when working with individuals and also treating individuals with respect and dignity, as well as using a client-centered approach. Moving on to the next bit. From the OT philosophy, we then move on to OT theory. And these are the conceptual models. Depending on the text or references that you might be using, you might find them being called models of practice or generic occupational therapy models, or in other texts, they are written as occupation-based models or just models. The conceptual models, they address the why we do what we do. So the theory acts as the building blocks for everything that an occupational therapist will do. It might be that you've worked with occupational therapists or you have seen occupational therapists at work and they did not explicitly mention the conceptual models or the theory that they are using. It doesn't mean they are not using the theory. They are still using the theory because everything that an occupational therapist will do is actually based on OT theory. So what does a conceptual model do? If you look at the top left side, you'll see that there's an Airbus there. Actually, it's not an Airbus. It's actually a model of an Airbus. And what does a model do? It helps us to see how the different concepts or different aspects are interrelated. From that model of the Airbus, we can see how the fuselage relates to the wings, to the wheels, to all the parts that we can see. So that's basically what a conceptual model does. Last semester, we introduced you to the PEO model, and it's shown on the top right side. If you look at that model, you can see it has got 3 aspects: the person, the environment, and the occupation. And we can see that when those are interacting, it then affects occupational performance. So that is what conceptual models do for us. They help us to visualize the concepts that are involved and also to get an insight into how these concepts are interrelated. And some of the examples of the models already we have covered the PEO. We're also going to be covering the CMOP-E, the Kawa model, MOHO, Vonner-Detroit model of creative ability, the PO as well. But maybe for this module, we're not going to cover all of the examples that I've given, but we're definitely going to touch on some of these models. Now we move on from the models. We then move on to what we call frames of reference. Frames of reference address the how we do what we do. So with the conceptual models, they were addressing the why we do what we do. Now we move on to frames of reference, which address the how we do what we do. If you look on the right side, you'll see that there is a frame. The frame provides the structure to be followed. It supports the building. It's not a model of the building, but it's actually the structure, the actual structure of the building. It's not an image that's drawn to scale, but it's the real building. Everything that's going to build is going to be coming on top of that structure. So frames of reference, they help us to get to know how we do what we do. They also describe the application of knowledge in a specific area of practice. So the conceptual models, usually they are broader. If you like, you might consider the conceptual model as the lenses through which we view our service users. So they are quite broad. But then when we come to the frames of reference, they are much more specific, as I'll share with you just now. So what do? They help us create and design concrete assessments and intervention plans, addressing specific. And take note, I've put specific in bold because each frame of reference tends to have a specific use in occupational therapy. This is usually because of their specific nature. And we tend to use more than one frame of reference, and we call this an eclectic approach when we are actually in practice. Some of the examples of the frames of references that we have, they include the rehabilitative frame of reference, biomechanical frame of reference, client-centered frame of reference, biopsychosocial, sensory integration, and so forth. So the specificity of frames of reference comes, for example, if I take the biomechanical frame of reference, the biomechanical frame of reference is a frame of reference that we can use when we know that we're working with an individual who has got difficulties in terms of their joint range of motion, difficulties in terms of their endurance, difficulties in terms of their muscle strength. So they are quite specific. So somebody who has got an orthopedic condition, maybe without any neurological involvement, we might be able to use the biomechanical frame of reference to start selecting our assessments and making decisions about interventions, as opposed to somebody who might be having maybe sensory processing difficulties. So for individuals with sensory processing difficulties, we might actually realize that biomechanical frame of reference is going to work for them, but maybe we're going to use a sensory integration frame of reference. So the frames of reference tends to be specific based on the condition or the situation that we're dealing with. But we're going to learn more about these frames of reference in this module. So then moving on from the frames of reference, we then move on to the assessments and interventions. So if I continue with the example of the biomechanical frame of reference, when we have selected that frame of reference, knowing the specific client or service user that we are working with, we can then be able to identify assessments that are linked to this particular frame of reference. Assessments, they come in different types. We have standardized assessments and we also have non-standardized assessments. Your standardized assessments, these are assessments that have been developed through lots of research, and they are validated tools, and they are very sensitive in terms of capturing the actual performance abilities or limitations thereof of our service users. Non-standardized assessments, these are sort of like assessments, like for example, observation, where we can observe someone performing an occupation, and then we can document our observations. They are not necessarily, they are not standardized. They are non-standardized because we are basing them on our observations, which sometimes might differ depending on who is observing. And then we also have occupational analysis or occupational assessments, environmental assessments, depending on the needs of the service user. We then make decisions to say, okay, if we're using this frame of reference, we can potentially use these particular assessments. We can also look at assessment of performance components, depending on what approach we're using, whether we're using a top-down approach or a bottom-up approach. So usually performance components, they are assessed when we are using a bottom-up approach, where we're looking at maybe measuring range of motion or muscle strength, not necessarily occupation-based assessment per se, but these are assessments that we can also include depending on the frame of reference that we are using. And then from there, we then look at the interventions. So the interventions that we can use in occupational therapy, they tend to fall under one of these five possible options. It might be we use educational interventions where we're educating the service user on how they can manage better with the condition that they have or the circumstance or situation that they have. Because remember, occupational therapy is not only focusing on people with health conditions or clinical conditions, but it's about enabling people to engage in occupations that are meaningful to them. So we might use an educational approach. We might also use maybe a performance skills training where somebody is being trained to acquire new skills for them to be able to engage in occupations that are meaningful to them. We might focus on modifying the environment. We might focus on providing the necessary assistive technology, or it might be about functional restoration, more of a rehabilitative approach. So this is in summary the hierarchy of occupational therapy knowledge. This is what informs our assessments and interventions. It comes from the OT philosophy to the conceptual models, frames of references, and then the assessments and interventions. Okay, I hope that was clear. Just to move on to another example that might help you to grasp the hierarchy of OT knowledge. So this was shared with me by one of my former colleagues, and they call it the occupational therapy tree of knowledge, where we are using our imagination. We like doing this in occupational therapy. So imagine a forest of trees where each individual tree is an individual patient or service user, and the forests are all individuals or service users on an occupational therapist caseload. Well, so keep that in mind. Tree representing service user, forest representing the caseload. Now, let's move on with our example of the forest and trees. Now we take the soil to be occupational therapy philosophy, the values, the beliefs, the assumptions that we use in occupational therapy. Take the roots to be the core values and the beliefs, sorry. The trunk, we take it to be the conceptual models of practice. The branches are the frames of reference, and the leaves, the assessment and the interventions that we use. So to put it all together, the occupational therapy tree of knowledge. All trees within the forest grow in the same ground and share the same soil, that soil being the occupational therapy philosophy or paradigm. With deep roots contributing to stability, those are our core values and beliefs in occupational therapy. Each tree requires its roots, the OT values and beliefs, to be grounded in fertile soil, the OT philosophy. Each sapling may grow into a different tree for one reason or another. That might be through the professional and clinical reasoning that we use in occupational therapy, which we'll talk about in this module. With a differently formed or sized trunk, that's the OT model or the conceptual model, and differently grown branches, those are the frames of reference, and diversely colored shaped leaves, and those are our assessments and interventions. Nevertheless, that's the important point. Each tree has a trunk. In other words, each service user that we are working with, there is an OT model that we are using. So each tree has a trunk, that's the model, and branches. So for every service user that we're working with, there is some form of frame of reference that we are using. And the leaves, which are our assessments and interventions. So I just found this fascinating and also an easier way for us to actually grasp that we use models, we use frames of reference to inform our assessments and interventions. Right, just a brief whistle stop on terminology. Depending on the setting that occupational therapists work, you might find that sometimes we use patients, particularly in hospital settings. It might be clients, it might be just service user. Service user tends to be sort of like universal and it works in many settings. I once worked in an organization that was within the insurance industry, and we didn't use patients, we didn't use clients, we didn't use service user, but we used customers for people who were injured in road traffic accidents. And then the other terms, models and frames of reference. Now, depending on which part of the world the literature is coming from, they might be used interchangeably. Models might be used interchangeably with frames of reference. For example, lots of literature from the US, they tend to use the term models for what other countries will call frames of reference. So just take note of that when you are reading, so that you are clear on, is this a model or is this a frame of reference? The best way to distinguish if you just see the term model being used is check whether this is about showing us why we do what we do. If it's like that, then it's a model. If it's about showing us how we do what we do, then it's a frame of reference. There's also the term assessment and evaluation. Most of the US-based literature, they refer to assessment, what other countries call assessments in OT, they refer to that as evaluation. So just take note of that as you are reading. You might find where it says evaluation while it's actually referring to assessments. But for us to be safe on this module, let's agree that this is what we're going to be using. We're going to be using assessment instead of evaluation. So when we're assessing patients, we're using assessment. We're not using evaluation. We're not calling it evaluation, even though in other parts of the world they use evaluation for assessments. And then for evaluation, we're going to be using the term evaluation to mean what other texts or other places they call it re-evaluation. What happens at the end of the OT process when we want to see whether our intervention has made a difference. And then for the term models, we're going to be using models for conceptual or generic occupational therapy models. We're not going to be using models for the OT process. As you will see, some of the OT processes, they've got model in their name. Okay, and we are also not going to be using frame of reference in place of models. So keep that distinction between models and frames of reference, as well as OT processes. Okay, so this is sort of like our toolbox. So we need to be able to call the tool according to the name that we can all understand, so that we know that we're using the same tool rather than using conflicting terms. Okay, yeah, that was it. That's the list of the references that I've used, and thank you very much.